Good morning. So we're going to talk about the administration of vaccinations, TB, glucosans, and pressure ulcers. These are our sites for giving flu shots, an IM injection. And key points, so we can give up to 3 milliliters of solution. If we're going to go into the deltoid muscle, it's just 1 ml. The needle length that we use is 1 to 1.5 inches. If we have a bigger person, we can use a longer needle of 2 to 3 inches. We want to get through the fatty tissue and into the muscle. We want to select the right bore size. The higher the number, the thinner the needle. For our flu shots, we use a 25 gauge. And then the preloaded syringes that we get already have a 0.2 airlock already measured into the syringe. And that's just an airlock. When you're giving the solution, it kind of helps keep it in instead of oozing out. You don't have to use an airlock, but it's kind of nice. If we use a highly irritating medication, we use a Z-track method. So it'd be like if we're doing an antibiotic injection. To assemble the needle, if it's not already assembled, you just firmly press and twist. Then when we're giving the shot, we clean the rubber top of the vaccine vial with an alcohol pad. We let it dry, pull back the plunger to 0.5, push the needle into the rubber part of the vaccine vial, inject the air, and that prevents a negative pressure. In order to withdraw the vaccine, we turn the vial upside down and withdraw the solution. To do the IM deltoid injection, which is where we typically give our flu shots, we start with an exposed upper arm. We give the shot in the center of an upside down triangle. You want to feel for the bone that goes across the top of your arm, and that's the acromion process. And then the bottom of it is about right at your armpit level, and you're going to go right into the center of that area. And that's 1 to 2 inches below the acromion process. So whenever we give an injection, we always check our physician orders. We make sure we have all of our supplies gathered beforehand. We withdraw using the preventing negative pressure. Inform the resident, provide privacy. We're going to prep the site with an alcohol pad. Proceed with the injection, pulling the skin taut, and inserting the needle in a dart-like fashion 90 degrees into the skin. When we're done, we discard the syringe and the needle in the sharps container. Of course, we never recap a needle. And then we document. We want to make sure that we document the location, the date, the lot, and the expiration. Tuberculosis. It's caused by bacteria, Mycobacterium tuberculosis. It can affect any part of the body, but it's usually the lungs. And it is spread through airborne droplets. The body can harbor the bacteria while the immune system prevents sickness. There's 2 forms of TB, latent and active. Just some fun facts. TB rivals AIDS as a leading cause of death from infectious disease worldwide. And it's most prevalent in India and Africa. TB drugs have become resistant, and TB drug resistance threatens to kill 75 million people by 2050. And the cost attached to that is $16.7 trillion. Giant rats can be used to sniff out TB in African prisons, such as Tanzania and Mozambique. So there's a good use for rats. Latent tuberculosis, I mentioned there were 2 kinds earlier. This is where the immune system is able to prevent the bacteria from growing. So the bacteria remains alive in your body, but it's inactive at this time. It can become active later in life, and those with latent tuberculosis have no symptoms. They don't feel sick, they're not contagious, but just that they can develop TB later in life if they don't receive treatment. Active TB means that the tuberculosis bacteria is growing within the body and it's causing an active infection. Symptoms of TB include fatigue, a slight fever, chills, night sweats, loss of appetite, unintended weight loss, and a cough that lasts 3 or more weeks, often producing a discolored or bloody sputum. There's typically pain with coughing or breathing, and it is highly contagious. People at risk for contracting TB. Immunocompromised people such as diabetics, those with HIV or AIDS, and silicosis. Medications that can affect the immune system, of course, would be chemotherapy drugs, corticosteroids, and certain arthritis medications such as Enbrel or Remicade. Being in close proximity of anyone infected with TB puts you at an increased risk. Traveling to areas with a high TB rate, such as Pakistan, Africa, India, or Russia. Any older adult that has a weakened immune system, people that are malnourished, people that don't seek medical care, long-term drug or alcohol abusers, or just being a healthcare worker. So to do a TB testing, it's an intradermal injection. Of course, we use the inner aspect of the forearm, and the serum is placed just below the dermis. We use a very small needle called a TB syringe with 0.1 mL of PPD solution. We insert it at a 10 to 15 degree angle with the bevel pointed up. And you want to, when you inject it, you want to get a wheel, and it should be about 10 millimeters. And you can see in the picture there's a little bubble there that measures 10 millimeters. Of course, just like any medication, we check our order, make sure we have all our supplies. We withdraw the 0.1 mL of solution by preventing negative pressure. Inform the resident, provide privacy. You prep the anterior side of the recipient's arm and proceed with the injection, holding the needle at 10 to 15 degree angle with the bevel pointing up, and you push just until the bevel is covered. And you should be able to get that wheel. If you don't get the 10 millimeter diameter wheel, then you need to repeat the injection. When you're done, you discard the needle and syringe in the sharps container. Of course, you never recount. And then you read the PPD in 48 to 72 hours and document the administration. So how do we read a TB site? You want to actually touch and you want to feel for an induration. You don't want to just look at it because you wouldn't see necessarily the induration. And then depending on the person, depends on the size of the induration. If your person's HIV positive or has had recent contact with an active TB patient, or if they have nodular or fibrotic changes on a chest x-ray, or an organ transplant, anything 5 millimeters or greater would be a reaction. A 10 millimeter induration would be a reaction for anyone that has recently traveled to high prevalent countries, as an IV drug user, a resident or employee of high-risk congregate settings, such as nursing homes, mycobacteriology lab personnel, anyone with comorbid conditions, children under 4, infants, children, and adolescents exposed to high-risk categories, and the average person with no known risk factors, you would want a greater than 15 millimeter induration. So just some important notes. A reaction does not mean that they have TB, it just indicates that there's been an exposure. And although it is rare, there can be an allergic reaction. So if a person has never been tested, you should ideally monitor them for 10 to 15 minutes afterwards. Of course, it's an invasive procedure, so we're going to use proper PPE, and we want to prevent exposure to bloodborne pathogens. So we're going to use our proper PPE and discard the syringe in the appropriate container. And moving on to blood glucose testing. Of course, we do this with the doctor's order to monitor blood sugar levels. And that way we can monitor the effectiveness of their treatment. Supplies that we gather: the glucometer, a lancet, an alcohol swab, gloves, sharps container, a disinfectant wipe, and a 2x2 gauze. We explain what we're going to do. We wash our hands, we put our gloves on, cleanse the finger that we're going to use with the alcohol prep. We use the lancet to obtain a drop of blood. We blot the first drop and we use the second drop. We apply the blood to the test strip, get our reading, use the 2x2 to stop any bleeding. Dispose of everything, disinfect the meter with a disinfectant wipe before returning it to your cart. Remove your gloves, wash your hands, and then follow your policy for your order. The injection, with the fingers pointing towards the elbow, you grasp the skin at the injection site with your index finger and thumb, about 2 inches apart. You lightly pull the skin towards the shoulder to create a small amount of tension and lift the skin off of the muscle. Hold the needle and syringe at a 45-degree angle to the skin with the bevel facing upward and quickly push the needle into the skin. Push the plunger to inject the medication. If we're using a preloaded insulin pen, you want to make sure that you attach the needle to the cartridge, and you want to make sure you prime the needle. Usually it's about 2 to 4 units. Different medications have different amounts, and it's usually part of the instructions with the cartridge that you're using. But typically 2 to 4 is it. And if you just look at the needle, you can see if it's coming out just a little bit, you've got it primed. And then you're going to pinch the skin as above, push the needle into the skin, and then count to 5 before you withdraw to make sure they get the full dose. These are the injection sites. We typically use either the upper arm or the abdomen. You want to make sure that you rotate sites. They get the best absorption rate as long as you're rotating. And then pressure areas. So we always want to prevent pressure areas on our residents. We do the risk assessment, grading scale to identify if they're at risk for developing a pressure ulcer. We do skin inspections. We should be regularly checking for signs of pressure and damage. I know we do weekly skin checks with their shower days. CNA, they're always letting us know if they see something when they're just doing general care. But you want to look for non-blanching areas, heat or swelling. You want the skin to be clean, dry. You want it hydrated. You don't want any rubbing or friction. And moisture, excessive perspiration, incontinence, that can all cause skin damage. Incontinence and pressure areas often coexist. Barrier creams are very helpful. Good nutrition is key for healing, for keeping the skin good. Positioning is very important. Side to side, we make sure we have a good cushion. Someone that doesn't move around very much, we want to make sure that we're assisting them with repositioning. And a cushion and a good mattress. So we stage pressure areas, and the way that we do that, it's kind of like an apple. A stage 1, you have a red apple, and it's just red. If you push on it, it stays red. A stage 2 is like if you just kind of peeled the apple, you just expose the skin, you've got a wound bed that's pink. A stage 3 is a little bit deeper. It's like as if you took a bite out of the apple. You could probably see some fatty tissue. And then a stage 4 is full thickness. You can see bone or muscle tendon. And that's a very serious pressure ulcer, obviously.
Exactly.
Something that would be unstageable would be kind of like a candy apple. Often it's just black. You really can't see how deep it is. You can't see what's under there. Or DTI. If you've ever, just think of a bruised apple, you know, you might try to cut into it just to cut the bad part out, and sometimes it's just on the surface, it's superficial. Other times it can go clear all the way down, and that's kind of like a DTI. You just don't know what you're going to get before it comes up to the surface. So you want to definitely avoid those. So we're going to demonstrate the administration of a PPD test today. And Abby and Bella just wanted to say hi. We'll go back there and do our testing.
Jack and Jeremy said they volunteered.